Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Osagie Ebekozien, MD, MPH, Chief Medical Officer at the T1D Exchange and an adjunct faculty member at the University of Mississippi Medical Center. Osagie, it's good to speak with you. Welcome.
Thank you very much, David. I appreciate the honor to join the show.
So I should say at this point that my company, Implicit, is a supporter, sponsor, contributor to T1D Exchange. But of course, the company doesn't get involved in the research protocols or publications. Osagie, I wonder if you could explain a little bit more to our audience about what T1D Exchange is and what your role there is.
Yeah, so thank you again, David. And it's a pleasure to speak with you. And I remember the very first conversation about almost 10 years ago, back in 2013, on this same podcast. So I'm glad you are willing to have me back on. But
Certainly.
In the past 10 years, I think my commitment to diabetes and my commitment to equity issues are still stay true. And yeah, the T1D Exchange, in my role as the Chief Medical Officer, I'm leading some of those efforts as well. So the T1D Exchange were a nonprofit. We're based here in Boston, and we are one of the leading real-world data sources for type 1 diabetes in the U.S. Our primary focus is really to bring together industry collaborators, researchers, and patients to use data to drive improvement. And we do that through a network of 43 different clinics, all coming together, sharing data and benchmarking and sharing real-world insights as well. And we also have a patient-facing research network with over 16,000 patients with type 1 diabetes. But I think the crux of what we do is really to use data to drive improvement and drive changes in the diabetes space.
So you've used two very important terms, real-world data and quality improvement. And I wonder if you could give a thumbnail definition for each of those.
Absolutely. So when I say real-world data, I mean data from everyday operations, everyday clinical care. So when any of the listeners goes to see a doctor in the clinic and information about your weight, your height, your blood glucose level or your blood pressure level, all that information that is being captured as part of your medical visit or your medical records, that information can be used to improve clinical outcomes in a bigger space when we aggregate all that data. And I should share that we do all of this with the strictest security and ethical standards. And all data we use are, for the most part, for some of the clinical work, are de-identified data. And we take all the strictest protocols in safeguarding that information. And we aggregate all this data to now uncover insights. So in one clinic that might care for 500 patients, it might be hard to really filter what's noise and what's a real insight. But when you start to bring together all this data, aggregate data from these different networks, and we use a different algorithms and a different analytical methods and frameworks to start to understand, is there something that contributes to this outcome? Is there something that might make this better? Are we seeing any association? Are we seeing any trend, any changes over time? And we feed that information back to the clinic, we feed that information back to the patient to help them improve and help them make a difference. And we were able to do that, for example, with COVID-19. Our group, at the start of COVID-19, we collected all the information for patients receiving care in the different clinics with COVID-19. And we were able to very early on in the pandemic, about a month into the pandemic, describe how outcomes were different for patients with diabetes as compared to those without diabetes, and how outcomes were different for patients being affected with COVID. And we moved on to publish a great deal of new findings that really informed some of the management of diabetes among patients with type 1 diabetes. So that's to give you a sense on how there's strength in bringing all these insights together, and we feed it back to the community at large. But then the second broad piece of quality improvement, which is how we actually help and support the different clinics to make change. So you think about any setup or any system, there are sets of processes that make up that system. So there are processes in how an exam is being ordered, or how a lab is, processes in how you get a device, or how you get referred to a specialist. All of those processes have potential room for improvement and have sometimes a lot of variation or differences across different processes. So our team at the T1D Exchange, we have certified improvement coaches and implementation scientists. We're able to really study the local processes and study the process across different setup, work with the site to think about how can we improve a system or a process. We test those changes, and if a change is effective or works, then we ramp that up and scale it and share that with other centers in the country looking to improve a specific process or a specific outcome. So that's how we blend those two worlds. We're collecting the data, using that to identify insights. And when we do identify insights, we work with the clinics and with our partners to actually make change locally.
So that sounds like it could be an iterative process. And I'm wondering what the tension is between seeing something in the data and trying to roll out a change in care management right away versus taking a more academic perspective, vetting it, reviewing it, submitting publication, et cetera. What's the tension there? Are you able to deliver more real-time care management improvements, or are we on sort of a publication schedule?
So that's a good question, David. And the unique thing about our approach and why it's different from a traditional research approach is that the iterative steps we take to our work and the innovative mind frame with which we approach issues. So we know that when you look at the pathway or the typical amount of time it takes for traditional research to make it into clinical care, sometimes it takes as much as 10 years for a new finding to actually start being implemented in the clinic. But we want to change.
I've heard longer than that, but 10 years would be good.
Totally, right? So but that's the pain where if it takes that long for us to actually make a change. But for us and a lot of our partners, and again, I should share that these partners, the hospitals working with us, so 43 hospitals now in the endocrinology centers in the US. So it's a pretty large cohort of clinics. But these are all clinics that are top-tier clinics and do have this culture of innovation, culture of improvement. They don't want to wait 10 years, 15 years, 20 years. So when we see a change and we iterate on that change and we test this change and validate this change, not just in one center, but in multiple centers, we're able to produce what we call degree of belief that idea works and that's the right thing to do. And that idea leads to better outcomes today. So when we can verify and validate that we're seeing improved outcomes, we don't want patients to have to wait for years for them to actually benefit from that improved outcome from as a result of changes in practice or changes in some of the operational changes that happen locally. So it's that approach to testing things, validating them, scaling them if they work, that really gets us to where we are and where we're able to make these changes. I should add that a lot of the changes we make are more operational changes and changes that there's already a very strong clinical evidence that this change can lead to improved outcomes. What we do is amplify that and test how that would really work in a clinical setting. So our work is a little different from a lab research or different from, very early stage trials. We are more coming in the late stage of the game on, okay, yes, we know that, for example, patients being on continuous glucose monitors, have been shown to improve outcomes for patients with diabetes, and particularly type 1 diabetes or type 2 diabetes on insulin. So we know that there's a lot of evidence already for that. There's a lot of literature, randomized control trials, all of those is there. But a lot of our patients are not on those devices that has been proven and shown to make care better. So where we come in is, how do we make that happen? How do we close the gap between what's been proven in the research and what's actually happening? And that's where we really bring in our QI and implementation science lens to close that gap by testing changes and seeing what's going to help us get there fastest, because we already know this will make a difference.
And are you confident that the centers that you're working with, it sounds like you're working with a broad population, but I have to ask the question, is it a diverse representative population? Are the learnings from the network applicable to a broader population at large?
Absolutely, David. And that's one of the criteria we actually use in selecting the centers. I should add that we're grateful to have been funded by the Hemsley Charitable Trust. It's a nonprofit philanthropic organization based in New York to actually do this work.
Right.
Well, this gives us the opportunity to actually be selective on who is part of this network, and part of that, a selection, criteria includes the diversity of the centers we serve. So I would share that, for example, one of our centers is, because I'm based in Boston, this is a center that comes close to mind, is Boston Medical Center. And Boston Medical Center is a safety net hospital here in Boston, serving a lot of minority patients, serving a lot of patients without, on public insurance, including some of the patients in the endocrinology clinic. We also have a center like Grady Memorial Hospital over in Atlanta, another safety net hospital, Radi's Children's Hospital of LA, that also serve a lot of publicly insured patients. But we also have centers that serve patients, Americans, and in rural regions of the country. We have centers across the different coasts. So our centers are spread across 17 different states and DC. So it really gives a wide variation in terms of the demographics. So our racial and ethnic demographic for the cohort of who our centers serve closely matches that of the US, and that's one statistics we're very proud of. And the same piece too with the economic demographic of who we're serving, because we've been very intentional to ensure that while we have top tier, prestigious private university institutions, we also have a lot of the other centers that do serve a different cohort of patients. So we can really learn from both worlds and in between. And that's been something we've been intentional about building in the past few years.
Right. If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Osagie Ebekozien, Chief Medical Officer of T1D Exchange. Osagie, we're talking about the work that you've been doing with centers around the country, including some research in the context of management of type 1 diabetes. And one of the issues that I know you've been looking at recently is inequities in health outcomes. And I wonder if you can speak to that and let us know what your quality improvement initiatives are finding along those lines, and what are some of the solutions you're identifying?
Yeah, and this is an issue very close to heart for me, David. I live some of these issues as well. So it's an area of passion for me as a leader in this space. When we look at our data for type 1 diabetes, and my team and I have published a great deal of findings on this. One of the papers, and we published, last year in a journal called Clinical Diabetes, it really looked at the inequities we were seeing in our network for using data for over 18,000 patients with type 1 diabetes across the US. And we identified just huge gaps and differences in outcomes for patients. So based on patients' race, even when we adjust and control for other things that we think might contribute to that, we saw huge gaps in what we call hemoglobin A1C level, which is a marker of glucose control over the past 3 months. We saw differences in diabetes ketoacidosis, which is an emergency, a life-threatening condition that sometimes can be mild and easily managed, but it still remains a complication that we try to avoid. We saw differences in patients presenting in what we call severe hypoglycemia, which is when the blood glucose levels are so low. And we saw all these differences across the outcomes we care about, both short-term and some long-term outcomes for patients based on race. When we compared the non-Hispanic white cohort to the non-Hispanic Black group, to the Hispanic group, to Asian American, and we could still see a lot of these differences. And we adjusted for a wide variety of things, and some of those differences still persist. And that's just one of the studies, and we've done quite a few to really do this. And part of the reasons why we also take the approach of doing these studies is we want to shine a light on some of these issues. And one of the common things we say in management is what doesn't get measured can be improved. So we really think it's important that if we want to really tackle the issues of inequities, we need to be able to articulate them in a very clear way. We need to show the data on how this is actually impacting people and by how much. And we've done a ton of studies to really show that even when adjusting for economic status, when adjusting for a great deal of other things that people might argue that, oh yes, this might be the contributor, but we still saw a lot of those. So when we dig deeper to actually try to understand what are some of the factors contributing to this, which we've been doing and also publishing on, we see that all of these issues are sort of contributed to by four major categories, I'll put that way. The first is on the patient to provider interaction or the patient to clinician interaction. We know that a lot of providers, well-meaning, caring for patients with good intention because they care about the improvement, they care about the outcomes. But our data and a lot of other data that have been published in this space, even outside of our network, have demonstrated that there is what's called implicit bias in provider-patient interaction, specifically when it relates to how providers prescribe or share or even care for patients of color, for non-Hispanic, Black patients, for Hispanic patients. And why this is called implicit is because when you do talk to a lot of the providers, none of them, almost all of them are actually shocked at some of these biases when they do see the data and they see some of their own biases. And sometimes these biases are deep within, and that's the whole idea of it being called implicit. It's been shaped over the years by a wide variety of things. So that's sort of on that first level on how does the interaction and the relationship between the provider and the patient contribute to some of these issues. Now, the second major contributor was saying to the inequities, it's on the clinic level, on the institutional level. And we've uncovered that there are a lot of local policies, local procedures on the clinic level that really contribute to some of these differences. So I'll give an example. When a clinic, for good intentions, decides that before a patient can be on a particular kind of diabetes device, you need to be able to check your sugars 4 times a day. You need to be able to, return my calls within 24 hours. You need to have this log, or you need to, do some of this piece or come for this training or come for this other component. Now, those things are typically most times done with the mindset of, yes, let's make this a very effective practice or an efficient practice. But for a lot of the patients that are already minoritized, underserved, that already experiences some of these inequities, those hindrances, those barriers that has been placed on the level of the clinic now even amplify these inequities. So it's the clinic itself or the center unintentionally now even contributes to some of these challenges. But then it doesn't end there. There's also a role of state policies, a role of the federal policies, and I actually will call out some of the insurance approvals and the approval process for that. And you think about what gets approved and what needs a prior authorization and what does not. And if you're on public insurance, why that's how different that is on those on private insurance. It relates to who gets to be on what device or on what regimen, on what treatment. So on the state policy, the national policy, the federal policy, that now contributes to some of these inequities we're seeing as well. But I think the biggest contributor of all of this is really the broader structural and systemic racism when we approach these issues from an equity lens. And that sort of transcends not just type 1 diabetes, that transcends type 2 diabetes, asthma, hypertension, cancer. And that's really more ingrained into how our system has been set up and how the policies from transportation to housing to social capital to economic capital, how all of those have really impacted why we're where we are now and the depth of the inequities that a lot of the patients of color experience.
So that, of course, is a very broad societal concern, and the clinical community around diabetes is not necessarily going to be able to solve that problem or all of those problems. But I guess the question is, what are some of those problems that you can identify and offer solutions for in the individual clinic level? Yeah. So you identify an issue and you're able to go in and perhaps identify the implicit bias, perhaps offer some training. But is there a clinical issue? Is there a clinical solution that you offer as well?
Absolutely. We do that, and we do that on multiple fronts as well. So we are big on trainings. We provide to our clinics racial bias trainings, health equity trainings, but we know trainings can't change all of these issues alone. And one of the things we're doing is we're trying to change the default setup for some of these practices. So what I mean by that is to reduce the bias that a provider might have. We're testing this out in a few clinics where, as opposed to a provider trying to make a decision on whether or not a patient should be on a particular regimen or on a particular device, because we already know that that device or that treatment is evidence-based, there's the overwhelming evidence that it works. We're working with some of our clinics to make that the standard and to make that, and we're calling that like an automatic prescription. So, and what that does is that takes away the element of bias. Because if we set up the system where whoever is seen at this clinic A, because we already have some guidelines that are beyond just clinical guidelines in the books or in a folder, but that our EMR, electronic medical record system, defaults to that, and everyone gets that prescription because there's a clear direct path there. And we're seeing early evidence that that's working to really close some of these gaps, because we are now able to change the default so that you would get that standard. Now, we're also trying a bunch of other changes, and some of them relate to the policies, the local policies in the clinic. So for clinics that have some stringent policies, we're working with the administrators on to try to help revise some of those policies with an equity lens, knowing that, well, Administrator A or Administrator B, when you set this policy like this is how it cascades and triggers and contributes to inequities. Can you allow us for 3 months, for 6 months, for 1 year to take out this piece of your initial process or initial policy and this piece that is stringent? Let's take this out, let's test it out and see if that works. And then we go back to them and show them like, hey, look, because we changed this protocol or this aspect of care, now we are seeing these gaps close. And again, we're seeing early evidence of that as well. So we're looking at this on the local policy level. We're looking at this on the local practice level. We're looking at this on changing the default to reduce the opportunities for some of those biases to play a role. We're also working with patient advocates and working with patients directly, particularly patients of color impacted by this, to be a voice and share their own experiences on how all of this really impacts them. But more importantly, David, we're taking this issue to the big P, the big policy level. We're using all this data we're collecting from our clinics, from our patients, from our other stakeholders, and sharing that data, all this data with our colleagues at the state Medicaid offices, our colleagues at other federal advocacy body, and really pushing. We are not an advocacy organization, but we really have a strong role to use our data and our insights to make big national changes outside the scope of what we're doing. As we testing ideas and seeing ideas that work, we're also scaling that and sharing that with other clinics in our network and with clinics outside of our network that are also trying to do the same thing, trying to work on the same issue. So these are just a few ideas on a lot of underground work going on. And we actually have a paper that was recently published that articulates some of this and also includes some reference to some of the work we're doing. But we really see this as a multifaceted approach to tackling some of these things, bringing in different stakeholders and addressing them from different levels.
Very good. Well, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or maybe expect to find has changed dramatically?
David, I hope that the gaps we're seeing in outcomes for some of the chronic diseases by race and ethnicity will start to close. And I don't think they're all going to be closed and equitable in 5 years. But my hope is that we'll be moving towards that direction to close a lot of these gaps. And by the way, to also emphasize that closing these gaps does not mean one group comes down or one group does worse. But our goal and vision about closing the gaps is that this rising tide can really lift everybody, but more importantly, that the underserved groups for the past number of years can really get a fair chance at having better outcomes, while everyone else also improves as well. We'll be better off, and we all can enjoy the benefits of that.
Something to look forward to. Thank you.
Thank you, David, for having me.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.